Hey y'all, it's Meredith, and today I'm going to talk about pneumothorax versus atelectasis. This is something that always confused me in med school, so hopefully this video can help make it clear for you. Disclaimer, I'm pretty sure I misspell atelectasis half the time during this, so please don't judge me. All right, let's get started. So how are they different? So one way they're different is the cause. Another is basically the imaging and how you diagnose. And lastly, the management is different. So really in every way, and we're going to talk about those ways now. All right, so cause. So pneumothorax literally means air in the thorax, air in the chest. So you have this potential space, right, between your visceral pleura and your parietal pleura. And so something's got to make a hole, right? So pop a hole such that that space fills up with air, okay? So I like to think about it in two ways. Outside in, so that sort of like a stab wound can cause that, versus inside only, like if a bleb were to pop. All right, and so you've got to remember from your basic physiology lectures the pressure. So you've got atmospheric pressure in your lung. Obviously, atmospheric pressure is outside, okay? But when you create this hole, this stab wound, for example, or this bleb popping, the pressure inside the chest becomes atmospheric too. And remember, it's supposed to be that negative pleural pressure. So the lung wants to collapse down and the chest wall wants to go out. So you're going to end up with two scenarios. And this is a very important distinction, okay? So I want you to take a look at the picture on the left of your screen first and then the right. So at the left of the screen, you just have garden variety pneumothorax. But on the right-hand side of the screen, you have what is known as a tension pneumothorax. And this, like I said, is a very important distinction. So it's important to think, why wouldn't the pressure build up and push that lung and mediastinum over? So one thought is that maybe it's not very rapidly expanding. Maybe it was a small hole, or maybe it's already sealed itself off. And also maybe the air has time to sort of resorb, and so it's sort of resolving itself. So maybe the opposite is true for the tension pneumothorax, where it maybe is a bigger hole, or it's not sealing itself off. It is rapidly expanding without signs of stopping, such that the pressure just keeps getting bigger and bigger and bigger from that extra air, pushing the lung and mediastinum to the other side. And it's important to know that the non-tension pneumo could ultimately become a tension pneumo if the air in the thorax gets big enough. So I'm just going to pause here to remind us why we care. The reason we care is because if there's that much extra pressure in the chest, at a certain point, it's actually going to put pressure on the heart, such that the heart is not going to be able to do its job and pump blood. And if your heart can't pump blood, then you could die. So the tension pneumothorax is an emergency that needs to be corrected rapidly. So what do we do for this emergency? Well, we want to make a one-way valve where the air can exit the chest but not get back in. And that is what's called a chest tube. So now let's move on to the cause of atelectasis. So what atelectasis really means is incomplete expansion, essentially. Okay, so an incomplete expansion of the lung is what you're going to be thinking about. So again, I like to think about this outside in. So outside in, obesity, right? Because you can't move your belly out of the way. Chest wall disease like scoliosis, and a pleural effusion, so fluid in that pleural space. Inside only, things like a mucus plug, something in that airway, malignancy, a cancer in the airway, or a foreign body, like if a kid aspirates a piece of corn or something like that. So there's my drawing, my little pleural effusion. It's going to put pressure going in. That's that wall, obesity, and then there's your mucus plug there. They're all going to want to make the lung collapse. So basically, there's no hole. It's just everything's pushing up on that lung, or it's blocking air from getting in such that it squishes down and it gets smaller. All right, so now we've seen it in cartoons. But what does this look like in real life? Here's a pneumothorax. The air is the big black area, okay? And the lung is actually the small, shriveled little thing right there. And then if you notice that the mediastinum is being sort of pushed away because there's a increase in pressure on that side. I want to point out here that that shriveled up lung I'm referring to is actually atelectatic lung. So not to try to confuse the picture more, but the lung in a pneumothorax is actually atelectatic, meaning it doesn't have any air filling it. The difference is that there's a bunch of air in between the visceral pleura and parietal pleura in a pneumothorax, versus in atelectasis, as we'll see in the next chest x-ray, the pleura is intact. And so there's nothing filling that space. And that's why, as you'll see, the mediastinum in just plain old atelectasis without a pneumothorax gets pulled toward the atelectasis because that lung is still adherent to the parietal pleura on that side. All right, this chest x-ray is atelectasis. It looks almost opposite. Instead of all black where there's air, this is going to be completely white. No air, probably from a mucus plug or something. And here the mediastinum goes in that direction toward the side of the atelectasis because there's a decreased volume because all of that lung is squished up. So lastly, this is just a picture of what we call bilateral atelectasis, meaning it's happening on both sides. It's probably from sort of a diaphragm weakness, or you could see this in obesity as well. I just wanted to show you this picture to see that they have small lung fields. The mediastinum stays in the middle because it's symmetric. All right, so lastly, what do we do? So in a pneumothorax, there's a couple of things. Number one, you could just monitor, just watch them, see what happens. Two, you can try to give more oxygen, and that's sort of a different discussion on the theory why that works. And three, like we talked about earlier, you can put a chest tube in. All right, so for atelectasis, it kind of depends what's going on, right? So if it's a plug, you gotta get it out, right? Get rid of the plug. And on the other hand, if it is a chest wall issue or obesity or something, essentially compression, pleural effusion, or the patient's not taking big enough breaths because of pain, for example, then you need to relieve that compression. So whether it's taking out fluid of the effusion or giving pain medicine or losing weight even, or things like that, okay? Getting out a plug, well, some people could just cough it out. That would be the easiest. And then you could also do a bronchoscopy, which is a procedure where we can kind of clean out the airways. All right, so in summary, a couple quick points. One, these are both collapsed lung. That is true and important to remember. But two, the causes are different, and that is an important distinction. Three, because of this, they behave differently. So you've got to remember that. And four, because of this, then you're going to treat them differently. So that's very important to remember as well. That's all I got. I hope you found this helpful. Please feel free to email me at mkgreer@emory.edu. Thanks for watching.